APBD patient since 2011 when I was diagnosed at the Kennedy Krieger Institute in Baltimore, Maryland. I had been dealing with the disease and had been diagnosed with hereditary peripheral neuropathy probably in the late 90s, early 2000s. And the reason it was hereditary because my brother also had similar symptoms and subsequently was diagnosed after mine with APBD. So the issue right now that I've been dealing with has been trouble with walking and foot drop and those kinds of issues, balance issues, which is pretty common to those of us who have APBD. At my last doctor visit with my neurologist, he recommended that I get a orthotic to help with my walking and foot drop and that kind of stuff. So I contacted my physical therapist, Cathy, who is currently having computer issues. I contacted her. I've been dealing with Cathy for 5 years. She's familiar with my current situation. I've provided her with all kinds of information that we have on APBD. So Cathy had me come in and do an assessment and an evaluation. She compared that with previous assessments that she had done. I felt that my balance and my walking and my foot drop was getting worse as I walked the halls. I live in a 55 plus community, and I want to walk with one of my neighbors. And when I was walking before I got the braces, my left foot was hitting the ground pretty hard and dropping. So it was time to make the move. So Cathy then hooked me up with Kris, who is an orthotist. That Kris is a certified prosthetist and orthotist with ability prosthetics and orthotics, and forgive me if I'm messing up the words. Kris, thank you, Kris. We then did a number of sessions and evaluations and testing of various orthotic foot braces, and came up with one which I've had for probably a month now. As I walk with my neighbor, I'm not getting the foot drop. I still apparently get somewhere the toe is hitting the ground first, but that's not really a big issue as I try and figure out what I'm doing. So with that, hopefully, I don't know if is Cathy ready?
What my plan to do was to go over some of the things that the physical therapist will talk through with you and assess to determine whether or not you might be a candidate for some of the braces that Kris is then going to take it over and show you. So when you meet with your physical therapist, he or she is going to do a balance and gait assessment. And there are several balance and gait tests that we do that are rather standard tests for the industry, the physical therapy industry itself nationwide. So these tests would be recognized by any therapist, and the benefit of the test is that they have very objective standards and specific criteria to be scored. So if we can get the first test that you might do would be what's called a 5-time sit to stand. So the therapist is going to measure the amount of time it takes you to stand up 5 times with your arms crossed. So this will give an indication of balance because you're trying to do it quickly. And that may be followed by what's called a Berg balance test. This is a 14-item test. And it primarily tests your balance. So David will remember, he's done this many times. You'll stand up, you'll stand with your eyes closed, you'll turn around in a circle, you'll reach, you'll bend over for the floor to pick something up, things like that. Then if we want to go to the next slide, the other two key balance and gait assessment tests that we've done are, the first one's called the functional gait assessment, and this is where your physical therapist is going to watch you walk under 10 different scenarios. So your normal walking pace, a fast walking pace, walking backwards, walking with your head turning right and left, looking up and down, walking on the stairs. And then again, each of those things will also be assessed. And that's where your therapist may pick up some of the gait abnormalities that we're going to look at, but this will give you an objective measure for how you're doing, rather than just saying, oh, I think you're doing well, or I think you may need this or that. And then the last one that is often done is called a 10-meter walk test. So this is literally the amount of time it takes you to walk 10 meters at a normal pace. And again, this will give your therapist and the orthotist an opportunity to really look at your gait over a 10-meter span and how quickly you are or not walking. It's not really a speed assessment, although it can be done that way, but typically it's used to just look at what's your normal walking pace. And then there are norms for all of these to determine and to compare and show whether or not there's progress. So the next thing we hope to bring up, Cathy, is the slide with the normal gait pattern. So your gait pattern is broken down into a swing phase and a stance phase. And then the stance phase begins when your foot contacts the floor. So typically that's your heel contacting the floor in a normal gait pattern, which requires you to have ankle range of motion and strength. So then it would be great now, I'm sure, hopefully, Cathy, you can run the video of the normal gait pattern. You'll see a woman on a treadmill, and then you can see her gait pattern. Let's see if I can. Okay, so you can see how when she strikes her left foot down right there, she hit her heel down first. Then there's the swing phase of the gait where her leg is up in the air. Then there's the stance phase of the gait where her leg is on the floor, or in this case, the treadmill. Okay, thank you very much. So let's go and look at now some abnormal gait patterns. And in tonight's discussion, we're specifically talking about abnormal gait patterns with that initial contact of your foot on the floor. It's abnormal in your stance phase if your initial contact is the middle of your foot or the front of your foot, because as you just noticed in the video, it should be your heel. This issue where you contact the middle of your foot may be called foot drop, or may be called foot slap if you actually hear your forefoot contact with the floor. And I think David may speak to more of that, and we may actually see that in that video. Then another abnormal pattern can happen more during the swing phase of your gait, and that's where you have a toe drag, where you're not really clearing the foot. And so think of that as tripping over your toes. We have a video to show that as well. So you're going to see in this video the gentleman walking from several different views, and you can really see kind of that foot slap where he does not bring his heel in contact with the floor. So the concern when you don't bring your heel in contact with the floor is that you're going to trip. Okay, thanks. That was perfect. So a person that has an abnormal gait pattern where, such as the ones we just described, may benefit from this ankle foot orthosis or the AFO. And you're going to work with your physical therapist, and he or she should look at your balance and your gait with your AFO and without your AFO so that there can be a comparison. And I think it's really important, David and Kris can attest to this, that you work as a team and the three of you work together because you have different input. Kris, your orthotist is going to give great feedback and input as to what adaptations are possible with the brace, and your physical therapist, who hopefully, it's all likely you've been working with him or her for a while, will have kind of a historical perspective as well, which is key because some days are good and some days are not as good, and we want to make sure that we're matching the brace to the person for each day and kind of the best case scenario. So it may take more than one visit to kind of narrow it down and figure out what's the best brace for you. At this time, I'm going to go ahead and turn it over to Kris, who's going to show you many more things about braces and kind of how we pulled the whole project together. Thank you again, and I'll talk to you soon.
Shall we take a moment to see if there are any questions in the group? Calliope, are people going to raise their hands? How are they going to indicate that they'd like to ask a question?
Oh, I'm giving them a chance to unmute right now. And anyone who would like to ask a question has the ability to unmute yourself and ask it at this time.
Hi, this is Jerry. I have a question. You are at a position that you're already walking and everything. What can be the steps for a physical therapist to get somebody to be able to stand and just be able to transfer and turn before getting into the work with an orthotic?
Obviously, it depends on your situation, but it's never too early to get an orthotist involved. Our evaluations are free, and to be able to see if, even if we do something that's more positioning versus something you're going to use for walking, so we can help. And actually, if you're going to transfer and just take that step or two, you know, to get from one chair to another, bed to the chair, that's fantastic. And we can do some type of device to get you from point A to point B. It doesn't have to be down the hallway like David does. So every person's individual. So again, it's never too early.
Is there some kind of pattern that's particular to APBD or other neurological causes as opposed to other causes? Or is it really totally individual and people have different patterns that are unpredictable?
There's not a particular pattern that I know of. I think that it's very important, even in cases, even in diagnoses where we do know there's a pattern, to look at the specific person. And so my emphasis would be to look at the specific person, even if you sometimes did see a pattern. And David is a good example of this because his right leg and his left leg are not the same. And his right leg and his left leg do not do the same thing every time. So while we were watching David walk, Kris and I would both say, he just did this. And then we'd look at each other and we'd say, but he did it on his left leg the last time. And at first we were thrown off and thought we weren't seeing it, but sure enough, that's what he was doing. So I think there's not a specific pattern, to answer your question, and that even if there were, in the diagnoses where we do see a specific pattern, for example, a stroke, it's hugely important that we're looking at that particular person and how they're doing, because they may do slightly different modifications. Your brain's an amazing thing and it will adapt and kind of get your gait pattern rolling for what is working for you. Hopefully that answered your question.
It did,
And I
yes,
just-
thank you.
And this is Harriet. I'd just like to ask, so you identified that there's an abnormal pattern with either the heel not striking first, or which would cause it either the midfoot or the forefoot to strike first. And are what we're talking about today either of those two abnormal things, or just the toe striking first? Where are we?
It can be any of those three, correct. So if the heel doesn't strike first, we would consider that an abnormal pattern. Whether the middle of the foot struck or the front of the foot struck would still be an abnormal pattern that could benefit from an AFO. If you have a toe drag, where during swing phase they're literally dragging their toe along, that person could benefit from the AFO as well.
That's terrific. Thank you.
I've experienced, the toe and the middle of the foot hitting as well.
Anybody else have a question for Cathy? Okay, then let's.
Yes, I
let's-
do. I do.
Oh, go, please.
I have a question. How do we find a team like you? I've never heard of, I'm not quite sure what the profession that Kris is in is called, and how do we find someone like you? Or a team like Cathy?
So a lot of times you can find through your physical therapist. I'm a prosthetist orthotist, and no one's ever heard of it until they need me. So basically what I do is brace any part of your body but your teeth. So from the little helmets that babies have to AFOs, I've worked with patients who are 4 days old, 104 years old. There's only 5,000-6,000 people in the US that do this job. So a lot of times you will find them in larger cities, but if you kind of think of orthotics, like either the ankle foot orthotics or the orthotics in your shoes, and I hate to say Google it for your local person, but if you can't find someone, your physical therapist can absolutely help you find someone. I'm putting the blame on you, Cathy.
My experience is I've been with working with Cathy, as I said, for about 5 years, and she introduced me to Kris, and we did work as a team to go through and determine what the correct solution was in my case.
Thank you very much. So, okay, again, my name is Kris Desjardins. I'm a certified prosthetist orthotist, so a CPO. I'm a fellow of the American Academy of Orthotics and Prosthetics, and I've been doing this about 15 years. My background, my first degree is in biomedical engineering, so I'm very picky on my alignments and how people walk. We did hear about drop foot and from Cathy, so I kind of skipped over a lot of that for that. Let's see. Okay, so you've talked to your doctor, you've talked to your therapist, and you've agreed to get a brace. So how do you go about doing it? You're going to find an orthotist or be recommended an orthotist. Evaluations with us are free. And that's a really good thing for you to know. We just need a prescription because part of our certification states that I can see people who are under the treatment of a physician. Okay, so with a prescription. And the prescription can just say brace eval and drop foot. It does not have to be incredibly detailed. We can always go back to your physician to get better notes if insurance requires it. And your orthotist can help walk you through some of that process. So we're going to identify the underlying cause. Is it a stroke or what's going on that led to drop foot? I love working with physical therapists, like Cathy said, because they have the history of the patient. I get to work with you for half an hour or an hour if I'm lucky. And you might be exhausted that day, or you might be really excited and practically skipping down the hallway. So I'm getting one glimpse in time. So getting to work with your therapist is really, really helpful in this regard. So my goal is to reduce some of the symptoms and increase your balance and mobility, is to keep you walking or moving forward in the best way possible, in the most efficient way possible. Because just because you can walk, sometimes we can fine tune that and make it safer. Because David was walking before I met him. You know, we just found a slightly different way of doing it. So I'm helping you provide a tool that you can use in your daily life. So an ankle foot orthoses, orthotists were not creative when we label things. So the O stands for orthotic. AFO is ankle foot orthotic. KFO, like the Forrest Gump brace that fell apart, is a KAFO, knee, ankle, foot orthotic. We just don't, not creative. They're going to help pick up your foot in also help you keep stable side to side. So I know today we're really focusing on drop foot and picking up those toes during swing phase and trying to get the heel down if possible, so you have a good heel strike, which then helps your knee advance forward, helps your shin advance forward, and helps you keep your balance, and helps prevent your knee from hyperextending if you just hit your toes. So I know this is a lot. Again, 15 years of this, trying to boil it down into 15 minutes, so there's no pop quiz at the end, okay? But as an orthotist, I'm also looking at your whole body. So we're gonna go over multiple styles of braces. Every patient is individual. Even if they have the exact same diagnosis, I might do completely different braces for two people, okay? Also, my goal is to give you the least amount of brace possible, because the negative side of bracing is that if I were to completely lock David up, he's no longer using his muscles. And if you don't use your muscles, what happens? You get weaker. So it's important to continue physical therapy whenever possible. And it's important to wear your brace, but to also do those exercises at home so we keep your muscles super active. So during your evaluation, a big thing we want to do is discuss your expectations. If you say, I want to go bungee jumping and be able to climb a mountain to get there, I don't know if I can help you. We're going to try to get you to reach your goals in a safe way. And sometimes it's, hey, let's get to this level of goals, and then over time be able to get more therapy and work your way back to your main goal. So you're going to have your physical evaluation. While you're sitting, we're going to check your range of motion, your manual muscle testing, kind of see how strong you are. We're going to do your gait analysis. So if you see in this picture, some of the things that I look for when you're walking is how far apart your feet are when you take a step. So when a lot of times when people walk, and David's a great example of this, is sometimes he would scissor. So it's almost like you're walking a tightrope, okay? So people don't walk a tightrope in their normal gait patterns. So that kind of ticks us off. That also, are you taking even steps from right foot to left foot, or are there some asymmetries there? And also, when you're walking, are your feet rotated in? Are they rotated out? These are all things that I need to look at in addition to your drop foot to get the best type of brace for you. At times, if we're doing a custom-made brace, we might end up doing a cast of a patient. So this is a patient I cast today. Sometimes, actually a lot of times these days with carbon fiber bracing, we're able to get small, medium, large, and then customize it to the patient. So we take our measurements, and we do check your insurance. You want to know how much is covered ahead of time. For example, Medicare covers 80% of bracing. So if you have a secondary, hopefully they'll cover the rest of it. But you always should know before they start fabrication how much they anticipate you should pay, and if they're going to get all the required paperwork from your insurance. That way you're not stuck with a big bill at the end. Sometimes it's inevitable, but at least we want to be prepared. The brace can be fabricated or ordered, and then you're fit. And then I highly recommend you return to physical therapy for gait training, and then follow up with your orthotist as needed. This is a mechanical device. You don't drive your car off the lot and never get an oil change. So you want to come back and just to see what's going on. And even 6 months or a year later, your gait pattern may have changed. Sometimes we can play with putting a wedge or a lift, like a little kickstand inside your shoe under the brace, and really fine tune your walking. So AFOs, there's a whole variety of them, from back in the early 1900s where we had the metal and leather, again, kind of with what you saw in the Forrest Gump movie, to thermoplastics, carbon fiber, and hybrid models. So the conventional type of AFO, it's minimal contact. That leather at the top goes around your calf. This is attached to a shoe. Oftentimes you have the one shoe you can use until that one wears out, and then, or we can put a split caliper where it can be transferred back and forth. You're not going to see this as often. It's a little heavy at times, but it's fantastic when someone has size changes because of swelling or edema or sensitivity. I'll also use them for patients who've been wearing them for years on end, because, you know, humans are creatures of habit. So then we're going to get into different types of thermoplastic devices. So trim lines are how far forward this plastic can come. So I don't know who else is a Patriots fan here, but that's me. This is my favorite brace that I have. But the more plastic that wraps around your foot, the stronger it is. So if I try to bend this forward, you see that I'm decently strong and I can't make this bend. So there are braces that are a little more flexible. So you can see in the picture compared to this one, that brace, you see if this picture doesn't show up. This is the all black one, but the less plastic there is, the more flexibility the brace has. And we can go any phase in between. There's no, we have to go 15.7 millimeters forward. It all depends on what you need. So this will help with foot drop, because when you go ahead and swing your leg through, this part picks your toes up for you. And then when you get to the end of your step, your heel is right there, so you can place that foot down. Then the foot rocks forward, and then this part pushes behind your knee to keep your momentum going. So that's how AFOs of all types can help. So articulated braces are like what I showed you, but there's little joints. Sometimes they stop, so you don't have the ability to put your toes down, so that way you don't catch your toe when you're swinging through. But when you're standing and you go to lean forward, you'll have that little bit of motion. So, and then we come to carbon fiber AFOs. These can come in custom made or custom fit. You have something like this one, which has a little bit of spring. The person takes a step and goes to roll off their toe, and if you guys can kind of see how this has a little bit of flexibility. So it rolls off, and then when you go to swing, it actually helps bring your foot up so you can't catch that toe on the ground, okay? They come in various degrees of stiffness and shape, because remember how I said that every patient is a little bit different, and we want to see what their knee and everything else is doing. Even though we're primarily treating drop foot, you might see a style like this that has a shin component, and you can see I can't bend this one the way I could that other style. So just goes to show you that these are just 4 braces that I've shown you, 5, 6, and I can't count. But there's so many iterations, and that's why it's really important to talk to everyone on your care team. Because if I see you on a really bad day and I put you in a very stiff brace and you show up in Cathy's office, Cathy's going to give me a call and go, what did you do to my person? And then your insurance may not pay for a different style, because as like a lot of things in healthcare, once you get it, it becomes yours. It's not something that you can return to us. That's why having those conversations and getting those expectations ahead of time is so incredibly important. So during an evaluation, after sitting and we do your range of motion, we might have you stand up. Now you can see on the picture in the middle that he's pretty straightforward, but this particular patient, who we're going to watch some videos of, the video was kindly provided by one of my fabricators. After standing for a while, he'll start slowly sinking. His knees are going to buckle a little bit. So we need to give him a little bit of stability, because just being able to stand for 2 or 3 minutes, and then if I give you a brace that allows you to do that, but then minute 4 and 5, you're collapsing, that's not the best brace for you. So, but if you look at the picture on the right, you see his foot kind of off center, and there's something else going on here. So that's, we're kind of seeing his foot rotated outward. His feet are pretty collapsed. So everything we have to keep in mind during our evaluation. So what I want you to do, I like this, it's not the best video, but I like the shoe he's wearing because it has that white line on his left foot, the foot you can see. You're going to see that it's almost like he's marching. The foot slaps, it just slaps and lands flat. Okay, so you're not seeing the heel stop. Okay, so even when he picked his foot up, his toes, he slid them around on the ground, and we'll watch this again. But his heel doesn't hit first. His foot lands in the middle, and then it's very hard for him to pick his toes up for the next step. So let's watch that one more time. So you can see right there. And then I don't expect people to necessarily catch this, but, and I'll play it one more time, but the first good step he takes, I want you guys to watch that he lands and then his knee goes backwards a little bit because he lost his momentum to keep him going forward. And you can imagine if you do that right there, I don't know if you saw, his knee kind of went back just a little bit, okay? So that's gonna lead to a lot of instability. So let's go to the next slide. So he lands in the middle of his foot, he catches his toes, his feet collapse. This patient doesn't have the ability to lift his foot up both with his muscles, and he doesn't have the full range because his calf muscle's tight. He externally rotates, I apologize for saying that wrong, and he crashes after standing for a while. He requires something very lightweight. He needs something with a custom arch. He needs knee stability, and having just that little bit of dynamic motion will be a good benefit for him. So he was provided a custom carbon fiber brace with a good arch, something like this pictured. And then we're actually going to watch him in his brace. Now, again, we're watching the brace foot. You're going to see his foot comes up, heel strike, heel toe, okay? And his foot isn't kicking a soccer ball. It's coming straight forward. And that's something that we're looking for to show improvement for this particular gentleman. Let's watch that one more time. So heel strike, and his knee's not snapping back either. Okay, guys? And this apparently is his first time walking in the brace. And I always tell people, first time's the worst. You're only going to get better from there. So, and you know how you get better? Physical therapy. So now, let's say you've been doing this for a long time, and just because you've been wearing an AFO doesn't mean it's the right device for you 6 months or 6 years down the road. So that's why it's important to constantly be in contact with your physician and your physical therapist. And if you're ever unsure, follow up with your orthotist for another evaluation, okay? So we're gonna watch this gentleman who wears AFOs. He's gonna come through, and right in the middle, you can kind of see his knee is just kind of snapping backwards. Well, that's not good because we have ligaments that act like rubber bands, and eventually that little snap will become really loose and be a bigger snap backwards. So I had to fix that for this gentleman. So again, one more time, you can see that snap back. So just because we do something for you doesn't mean it's the end all be all, and it's constantly a work in progress, okay? Now, I don't know if you guys recognize this gentleman right here, so who was kind enough to show his video. Now, see how he's crossing his feet over just a little bit. I'm not picking on you, David, I promise. But then some of his steps he doesn't. It's a little bit inconsistent. That's showing us a little bit of instability right there. And Cathy and David, please feel free to jump in. So, but you're kind of seeing his toes are kind of gliding. You can kind of see his toes come up on most steps, but some steps you can actually almost hear it slide across the ground. So, and he has an audible snap or a slap in person, okay? And then what we did during our trials, you can see heel strike on every step. Now, notice we're making him go, he chose to, but we want our patients to go into tiny little spaces, because who has a tiny space in their house? We have bathrooms and we have kitchens. So you don't want to just try your brace on in a really, really wide hallway and go, woo, I got it. You want to be able to turn and to be able to maneuver in this brace. Looking good, Cathy.
Not me.
There we go. So this brace is an anterior shell, because the shell is on the front of his foot, or in front of his legs, and it's helping provide a little bit of knee stability and extension. That's my favorite part. One, him walking really well, and Cathy's little dance. So let's go ahead and watch that one more time. So his knees are not snapping back, but he's not buckling. He's able to walk with his cane, although we do like him walking with the walker, especially when we're not around. His toes are coming up. See, you can see the bottom of his soles right there? Okay. And it's very consistent. Every single step is a heel strike. He's not rotating out or in. So we're really improving his, what's called the line of progression, how he's walking. Now, we did end up going with a device that was even a little bit more stable than this. And let's see, David, do you want to say anything before I?
Yeah, you mentioned about the cane versus the walker, and ever since I've got the braces, I've been using the walker predominantly in the house, outside of the house. I was a little reluctant in going outside with the walker, but recognizing that it's a much safer means of transportation. And I did actually overcome and coordinate the collapsing of the walker and putting it into the car, which was a challenge, but I've got it. So
Well,
something,
David, maybe you want to also talk about how quickly you went from the amount of time it took you initially to put the braces on to how quickly you're able to put them on now.
Yeah, one of the things that I forget, I think Kris said, preload your braces, which meant put the pant leg on the brace. So that was a challenge, and I did find that I can put the brace on, my pants on first and then the brace, so that made it a lot easier. So I went from, like 5-6 minutes to down to where I can do it like in 2 minutes. Get the brace, get the brace on with the shoe and get it all tied up and whatnot. So it is a bit of a challenge to do that, tying it, crossing the legs or bending down, so you just need to work it, but it's certainly doable, and it's certainly safer, the result.
Absolutely. And then one thing I would say about walkers as well with braces is that make sure it's the appropriate height for you. Work with your therapist for that, because I often see people come to my office and their walker's too low. So they're leaning forward, so it tilts their pelvis and puts more pressure on the ball of their foot or causes their knees to bend. And that changes the positioning of the brace. So you're almost fighting the brace rather than using it for the tool it is. Okay. So everything is a tool.
Yeah, let me just add to that. The walker is really important, and the height of the walker is important. I'm finding that I'm getting more pressure on my shoulder blades as a result of the walker. And Cathy adjusted it, but I think we need to kind of play around a little bit more with it and maybe go to a different type of walker.
Sometimes having the seat right there makes you kind of lean over the seat instead of having the walker right up to you. But again, it's what works within your life. And these are really important things to have that discussion. Anything either of you would like to say before I?
One of my experiences as I do walk the halls with my neighbor, as I get further into the walk, I find that my balance and my walking gets worse. The walker gets ahead of me, so I'm leaning over more. So then I know it's time to pack it in and go home. But you need to be aware of these things. You need to be aware of what is normal for you, what is safe for you, and that's really critical. Is that whole safety issue.
Absolutely. Just one more real quick thing to point out with this is, remember how we saw the last video, how he was walking a tightrope and switching his legs kind of over? He's a lot more stable, and you can actually see a gap between his feet for most of his steps here. You can see actually between his feet, and it's a little bit more consistent of a gait pattern. So those are some of the improvements that we do see, even though he does have a narrow gait. It's a lot more stable. So, and again, this was during a trial. It only gets better from here. There we go. So big takeaways is work with your team. This is how to spell orthotist for anybody out there. So doctor, therapist, orthotist, case manager, everyone is part of your teams, and you guys are the quarterback. There's many, many options. Had David worked with a different orthotist, he may have ended up with a different brand or different style of brace. It's all about communication to see what works for you, and there's not one solution. So discuss what some of your needs are prior to fitting. Do you have stairs in your house? Do you find that you always have to work in tight spaces? Do you have a back injury and that's going to prevent you from leaning over? Do you have issues doing straps with your fingers? These are different accommodations we can build into the braces, but it may limit what brace style we choose for you. So we want to make sure a lot of that is done up front during that initial conversation. So don't be afraid to speak up, okay? Cathy kind of alluded to this earlier. There's textbook, there's what works for, or what we say we're supposed to do for one person, and then there's what actually works for you. So this is what I tell all my patients. I've done a lot of schoolwork and a lot of continuing education, and yes, I know what I should be doing for a patient who walks in with a certain diagnosis. But a lot of times that book goes out the window and we find a creative solution. So also, it's sometimes possible to try on custom fit devices, such as what we did with David. I didn't make a custom-made device that was cast to him. Once I make a custom device, or had I cut all the straps or the toe plate to fit just to David, it would be his. Okay, so just be very aware of that and have some of that conversation ahead of time to make sure you're not committing to something you weren't prepared to commit to. Get adjustments if needed, even months later, and follow up with your therapist and have the annual orthotic follow-ups, especially because carbon fiber braces tend to have an 12-month warranty. So I try to see people at 11 months just to make sure there's no little cracks or things. So David, make sure you put that on your calendar.
I thought about that this morning. And I said, oh man, I got to do that. Sorry, Kris.
Yep. And then, so good luck to everybody. And yeah, and thank you guys very much for allowing me to speak with you guys today. I really do appreciate getting to show you a little bit about what I do.
This is wonderful. This is wonderful. Thank you. And you're not done yet because we do have questions, right? So why don't,
Kathy's going to answer
Calliope,
them all.
if you would allow people to have the mic privilege. And in the meantime, while Calliope is doing that, let me just ask you a question or two. You talked about David kind of hunching over the rollator or walker that he was using. There are other kinds of walkers that are tall. I mean, really tall. Why would that not be the go-to for somebody with this kind of gait issue?
So, I mean, Kathy might be able to answer that better, but it's also bulk, and we don't want to restrict. You don't just want to rest on it and have your core. We want you to use all your other muscles too. They're also not easy to transport. Kathy, if you want to.
The functionality of those is something that you really need to consider. David and I talked recently, just briefly, about those. And what you want to make sure is storage and then transportation. So to get the style with the seat, the rollator in and out of the car, it's a skill, and you can develop it and get much quicker at it. But then once you go to the taller walkers, you're talking about putting a lot more in the car. So I think that would be the biggest consideration there.
Yeah, one of the other Kathy, one of the other considerations I was thinking as I was thinking about this was, because I've noticed every once in a while the walker will kind of tilt a little bit, one of the wheels would come off. So I'm thinking off the ground, and I'm thinking that, well, if you got a higher walker, that it may present a greater tendency to tip over since it has a higher center of gravity.
That's true. That's true.
Another question.
Some of my stroke.
Oh, sorry. Another real quick question. I noticed that there were some kind of wraps around David's calves. Why is that? And is that forever going forward?
So you mean something like this?
No, around his calf.
Oh,
Oh.
you put on.
That was my sleeve.
Sleeve.
Yeah, that was
that's
to
part of
contaminate her sample. But I don't wear.
So part of it.
Yeah, I don't wear that now.
Yeah, and he also didn't have high socks, so I kind of did it for cleanliness. And also sometimes this can, even though this is a really nice material, some people don't like the feeling of it moving against the hairs on their legs, and they're in a location that it's too hot to wear a full-size soccer sock all the time. So you can just cut a piece around and just put it around the place that irritates you most.
Thank you. Who else has questions?
I have a question. Can you hear me? Yes?
Yes, go.
Okay, great. Okay, this is Heidi. I actually have two questions. One, and David sort of answered this, but I was confused. I was going to ask, does this help you to walk without a cane? And he said, actually, he went from a cane to a walker. So that didn't sound good. Yeah, go ahead.
Yeah, I mean, Heidi, the answer to that is just that it's safer. I can use the cane, but I don't feel stable as I did before. I'm just trying to,
Is that because of the orthotic, or is that because you're just getting worse?
Yeah, just more, like Kathy and Kris said, you ought to think about using the walker instead of the cane for safety purposes. And I said, sure. And I got home and I said, they're right. So thank you, Kris and Kathy.
Okay.
Unfortunately, I think that's the progression of the disease. And so that is the benefit of having worked with David over the years. So the walker, and then also knowing David, so the walker is safer for him. He is a walking buddy. He can converse. The point of is to go out and walk and have a conversation with his friend and be able to get some exercise and not be so focused on whether or not he's going to fall down.
Gotcha. Okay.
Yeah,
it does depend on the individual. Go ahead, David. I'm sorry.
No, I think there is the progression of the disease kind of warrants that. And I know in my brother's case, my brother was 5 years older, and he progressed from a rollator to a chair, you know, one of those fancy chairs. So, you know, it is a progression, and you know, you just need to be safe. You know, I think that's the bottom line, is the safety of it. Sorry.
Heidi, did you have a second question?
I did, thank you. I'm not sure if this is superfluous or not. Does it help you to, does the mechanics of the AFO help you to learn to walk better?
I'm not sure that I'm getting hung up on the word learn, but I do walk better. One of the things, you know, I find that if I'm not thinking about it, I get sloppy. It does force the leg, and I know Kris has explained it to me, and I'm no genius on the on the mechanics of it, but it does keep my foot from hitting the ground, dropping. So that's you know, important. So, you know, my neighbor, as we walked, you could tell that I was walking much better. So I'm not sure.
So Heidi, what you're gonna find is when your foot drops, a lot of times you have to compensate for it. So your knees bend a little higher, you end up marching, or you end up swinging your legs around. So if we can use the brace to take care of your ankles and position your foot in an appropriate position, you technically are walking in a more efficient, and I don't always like to use the word better, but that's what I think of it as, whereas the rest of your body is able to function in a more normal gait pattern, and we can just let the brace take care of the feet, so you're not working as hard.
Okay, thank you.
David, do you feel like you're not working as hard?
Huh? I'll never admit I'm not working as hard. I'm working harder, not harder.
Oh, do you feel like it's less concentration or less effort to move through the gate?
Yeah, I think so. Yeah, I mean, just I did have to work hard to you know, think as I was thinking about the walking, making sure that you know, and Kris and Cathy are right about, you know, sometimes it's my left foot, sometimes it's my right foot, that, you know, my right foot has some little pain by above the ankle on the outside, but, you know, the foot drop was worse on the left leg. It was slapping down. So yeah, I think there's a lot of stuff going on that is still going on, and this just helps correct it.
We have time for
David.
2 more questions.
Oh, sorry, go ahead.
We're kind of at the top of the hour. We have time for 2 more questions.
Sorry,
Who's got a burning issue?
I have a question.
Please go ahead, Paul.
Oh, hi. Yeah, I just wanted to know, so before I get to the point where, you know, I'm wearing a brace or using a chair, are there any physical therapies or exercises I can do to, you know, help the muscles in my legs and help me walk better before I resort to medical equipment?
Yes, is the short answer. So I'm not sure if you've seen a physical therapist before, or you have a physical therapist in your area. Someone had asked earlier, how do I find, I think she was referring to an orthotist, but I'm not sure if she was also asking about a physical therapist. You can go on the American Physical Therapy Association website. So that's the APTA.org, and they will help you find a therapist in your area. You're looking for a therapist that treats patients with neurological diseases. And he or she would then be able to do those balance tests and help you with everything from the exercise program for strengthening to the exercise program for balance to the assessments to whether or not you may need a brace. Did that answer your question?
Yeah, that sounds perfect. Thank you.
And not as a plug for my profession, but sometimes having the tool in your back pocket for the days that, not technically your back pocket, but to have a brace that you could use when you're going out in the community, but maybe you don't use it at home, but you start that earlier, can help you keep that level of energy and just use it as a tool, not something you have to commit to all the time. So that is something I do recommend. So, but I understand it's a big mental jump also.
A burning question from our group. Don't be shy. You're not going to get these two people here.
I'm going to raise a question. I think, David, you said you're in Baltimore area?
I'm in Silver Spring.
In Silver Spring. And Kris, I mean, obviously, travel is prohibitive, but do you see people from out of town occasionally? Is that a reasonable thing to consider once travel becomes possible?
It's definitely something that we would see. You do often require multiple appointments though. So I would be more than happy, David and Harriet have my contact information if you are having an issue trying to find someone locally. But I am available if you do need me. But even just having that conversation is absolutely not a problem. So.
Okay.
Yeah, and let me, express what was said before about the team approach. As I said, I've been dealing with Cathy for almost 5 years now. And I know as I was going through the various phases, Cathy and Kris were kind of talking and I'm walking and I'm not hearing nor understanding what they're talking about. And they're talking between themselves like, pig Latin as girls did when I was a teenager. But just kidding, Kris. They were just kind of doing their thing and making an assessment of what would work, which was important. And selecting the brace that would allow me to walk safely.
But I'm on some national boards and can definitely find someone in your area if you're having a hard time. I can definitely make that recommendation.
We need to express our thanks to all of you who made this evening possible. Cathy, Kris, David, who came up with the original idea, Calliope, who has saved me from sweating bullets. Cannot do this without you, any of you. And of course, all of the folks who are in our room right now, our Zoom room.